So let us start with just a one that's really a kind of a low-hanging fruit one for Dr. Dillon. Can you explain the difference between dotatate and dotatalk?
Dotatate and I'm not sure that. Dotatate and dotatalk. So
there's your answer.
This is really tough, this dotatate, dotatalk problem, I tell you. So dotatate and dotatalk are two very closely chemically related substances. They are both essentially artificial forms of somatostatin, the hormone. So they are very closely related chemically to lanreotide or octreotide. They are what's, rather than using lanreotide attached to gallium or copper for a PET scan, we use dotatate attached to that. But they are, think of them as just artificial variants of serotonin, and we use them interchangeably. Essentially, there may be minor differences in some people what lights up on a dotatate or a dotatalk. I'm not impressed that there's a huge difference between them.
Okay, super duper. Okay, so then Rachel. Okay, so we're going to give Rachel some eyeballs. So when you are counseling your patients as they are entering therapy, when they say, "Can I still drink alcohol if I have metastatic neuroendocrine? And does it affect lanreotide?"
Good question. So first, I'm a Wisconsinite, and so I come from drinking culture, and I know better, but I understand that this is a question that can impact social lives, make us feel normal. And so there's a couple things. One, if you have carcinoid syndrome, I'm going to ask you how you tolerate alcohol. If it makes you miserable, you're an adult, make your own decision. Two, you have a tumor that might be in your liver. We need to talk about the health of the underlying liver. Our liver can only metabolize so much alcohol, and so generally I'm going to limit people to safe amounts for their liver. That's going to look at like something like 1 glass for a woman, maybe 2 for a man, but spaced out over time. We're also going to talk about what size are those glasses. Again, I'm a Wisconsinite. So it's rarely an absolute no, but I think it comes down to a careful decision regarding risks and benefits. Do you have underlying fatty liver disease? I'm less worried about any interaction with lanreotide.
Good answer. Okay, so how about one for Dr. Howe? Pretty easy. I think you may have actually sort of covered it, and I don't know when this question came in. So how do you determine, or how do you counsel patients when to get a second opinion regarding surgical recommendation? And in particular, they're saying either to have surgery or not have surgery.
Well, I mean, the most important thing is that you're comfortable with that person, and that person shows they have some experience with these tumors, they understand the issues. So, you know, I think if you are comfortable and the person reassures you that they have experience with these tumors, then I think you don't necessarily need a second opinion, but it again, it's up to your comfort level. Or if they don't have the multidisciplinary expertise that you're looking for in follow-up. I mean, there are a lot of surgeons who just operate on people and then they leave it to the medical oncologist to follow them. I mean, at Iowa, that we kind of follow everybody. And if that's the situation you're looking for, you may want to go to a different place. I don't know if that really answered the question, but
I think the surgery question, since Jim and I are both surgeons, is really in the eye of the beholder. I feel like always get a second opinion. If you you're feeling like you aren't 100% comfortable with the decision, because even if you're hearing the same thing out of two people's mouths, it makes you feel better about the decision. And I do agree with him, is that people's comfort levels, we can't force surgeons to have a comfort level that we may have, and it makes them look nervous, and then you're nervous, and the whole thing just, as you're just better off getting a second opinion. I do think that when people say, oh, do I need a second opinion from MD Anderson, or whatever, I'd say, well, no, if someone was saying, hey, I'm gonna get your opinion from me, or I got this opinion, and then they say, oh, do I need a second opinion? I would say, well, can I just choose the second opinion for you? Because I think they're going to give you a really balanced opinion, like Dr. Howe, as opposed to just getting a second opinion because you believe that that center should, because of a reputation, have then someone that may feel comfortable. And so I don't think that necessarily, you're going to get the opinion that you're asking for really just by getting a random second opinion. It should be a thoughtful second opinion from someone that does a lot of neuro.
And I just wanted to add something to that. And one is, some of these really great centers like Memorial and MD Anderson, they're very medically, oncologically driven, and they actually don't do as much surgery there as, we think, many of us would think would be appropriate. So even though those are great names in cancer, in neuroendocrine, they're really good for medical oncology trials, but they often don't refer patients to surgeons, because I know several surgeons who work there who are like the Maytag dishwasher? Yeah, repairman. They're just sitting there lonely. And then the other thing is, it's your life, right? I mean, so it's okay. Don't worry about hurting people's feelings by getting a second opinion. I think most of us, are not going to have our egos crushed by you seeing somebody else and seeing what they have to say. So it's your life, and you have to be comfortable.
Okay, so this is going to be to the thing. These are actually quite funny questions because we've all lived in neuroendocrine. To the two people that have been in neuroendocrine the longest, so that's going to be Joe Dillon and Jim Howe, because they are referencing a well-known NET specialist who commented at a large group of NET patients at a national conference that there may be some link to the determination of neuroendocrine cancer in drinking large amounts of coffee. So are there any research studies being conducted to determine the cause of neuroendocrine cancer? And is there anything you may have known? You may have been at the meeting where someone said something. But then I throw, or Rachel can tell you whether or not now you're taking away the alcohol.
Don't take away my coffee.
Don't mess with certain things. So I don't know of any coffee linkage. You see these studies coming up with caffeine and colon carcinoma and caffeine and this, and 5 years time we see a study showing caffeine decreasing colon cancer. We at the University of Iowa and at many other places where we've been looking for the causation of cancers. Unfortunately, with cancer in general, not just neuroendocrine tumor, we don't know the causation of the vast majority of cancers. We know a few of them. We know mesothelioma and asbestos. We know that cigarette smoking does bad things. So we've looked at all the usual culprits for neuroendocrine tumors, whether it's cigarette smoking and alcohol, or I can't remember if caffeine was in the list there, but petrochemical exposure. We haven't found anything, or my colleagues at College of Public Health haven't found anything like that. So I can almost imagine which neuroendocrine tumor specialist said that, but I don't know of any. It didn't pan out. Things didn't pan out.
And statistically speaking, that person may no longer be with us. Okay, so this is another really good question, because I think you touched on it, Dr. Howe. I think that there's some confusion about sort of like the scar tissue and the whole concept of peritoneum. And I think you briefly talked on it, and I think I had a conversation about the complexities of peritoneal involvement. Because this question is asking about how often do NETs show up in the scar tissue after other surgeries. Like, say, for example, someone's had a small bowel resection and hysterectomy or things like that. How do you interpret something that is showing up in the quote-unquote scar tissue in a patient with a known seemingly mid-gut neuroendocrine tumor. And so pretty much I'm saying, do you interpret it that is that it was peritoneal involvement the whole time and it's not really scar tissue?
Yeah, I would agree with that, Mary. You know, I don't think there's anything about scar tissue or fibrosis that necessarily causes neuroendocrine tumors to form in that area. So I would conclude that that tumor was already there from peritoneal seeding. So I don't think it happens in scar tissue, but there may have been a tumor there because it seeded the inner lining of the abdomen in multiple places.
Okay, another one for Rachel. Are there any studies or trials? Isn't it like being like a pop quiz? Yeah. You aren't betting any money on it though. Are there any studies or trials on the effectiveness of melatonin in the treatment of NETs, and how exactly would melatonin work in that situation?
I don't know that I am aware of any studies in with using melatonin. Certainly, we've used it to try to help people who have had sleep difficulties, but I'm going to defer to my colleagues to see if they have a deeper answer. This is as a PA when you tap on your physician for collaboration.
Okay, and here's the
And
point.
your collaboration will generally agree will generally agree. So no studies, but a good night's rest is a wonderful thing.
Yes, and I do know that there was a period of time where they were using higher than average doses of melatonin and other cancers. I just don't remember them ever using it. Okay, so then these are the other randoms. We don't have our PRT people, so we'll just sort of throw it out to whoever can do it. So someone has a question about alpha particles and the percent of kidney damage, and so is there, I suppose, something that we can comment on? Iowa is actually a super strong program in really novel PRT, things that they've even almost made themselves on the Iowa campus. So any concerns with alpha particles with respect to kidney damage compared to beta? I think you guys wrote a paper on that.
I can't remember if there was a paper come out or not, but I have concerns about alpha particle and kidney damage. I think that, when I started seeing papers on alpha particle PRT, I was super enthusiastic because what you see in early papers, in early clinical studies, is you see a picture of a PET scan before the treatment, and then you see a picture of the PET scan 6 to 12 months afterwards. And it's far and away, clearly, no doubt about it, better than beta particle PRT. And I figured, hey, it's PRT. We know all the side effects of PRT. Well, no, it's not quite the same. So, alpha particle PRT is actually the Mark IV version of PRT. We had indium PRT in the 1980s, we had yttrium PRT in the 1990s, we had lutetium PRT, which is now our currently FDA approved one. And with the yttrium PRT, 10% of people got kidney damage. But we, as in they, experts at the time, figured out how to deal with that, and that was giving you that infusion of amino acids that protects the kidneys, and that protects the kidneys beautifully, and lutetium PRT really has little kidney damage at all. But I have patients, in my first 20 patients that I had going to alpha particle PRT, I have 2 of them now that are on dialysis or getting close to dialysis, and all of my colleagues who have some exposure to alpha particle PRT have stories like this, and interestingly, the first group to do the alpha particle PRT were the group out of Houston. And to my knowledge, they haven't produced their data on kidney function yet. They've produced their data on other side effects of alpha particle PRT, including a very unusual side effect of spasm of the esophagus or narrowing of the esophagus, which we didn't see in regular in FDA-approved PRT. But so I have concerns, and then we really don't understand that different form of kidney damage that occurs in alpha particle PRT. So now the entrance criteria to get into alpha particle PRT clinical trials are much more stringent in terms of kidney function than what we had initially, because this concern. So there's a little question mark over what's going on there.
I was going to add to the stricter criteria as we do start seeing results from more of these trials. It's going to lead to the question of when we start pushing it in a real world patient population, where is that cutoff going to be? Right now, most of the trials have a creatinine clearance of like 60, which is sometimes a really hard thing to meet. And so you're like having patients make sure they're super hydrated before they do their blood tests the day of treatment, meet that eligibility criteria. So, we'll have some safety data, but knowing that's not going to really match our average patient, it's, I think, going to be something that as we start seeing approvals, we're going to have to be cautious as we move forward.
Yeah, I also think that it is muddied by the fact that a lot of the patients that enter those trials have been heavily treated up to that point. And so since we don't really look at the cumulative effects of liver-directed therapies, chemotherapy, recovery from surgery, and all the stuff that we do on the kidneys, and then the patients are obviously aging and your kidney function declines after the age of 40. And so we were putting people on the alpha trials that I think had additional vulnerabilities. So really, really appropriate question, great question. But I think that like for most medical decision making, it's what you're going to invest in it for then the outcome is there. I think the medical oncologists deal with that all the time with chemotherapy-related toxicity. The issue they have is it's not like the kidneys, the sort of dialysis rebound really nicely once they start to struggle. And so I do think that even in heavily treated patients, regardless of whether or not you're doing 2 additional doses of PRT or you're trying to do liver-directed therapy, squeeze in some liver-directed therapies, the kidneys do seem to be increasingly more vulnerable the more treatment people have on board.
And I'm heartened by the fact that previous type of PRT, Yttrium PRT, we used to have a lot of kidney function problems, but clever people solved that issue, and we figured out what needs to be put in the magic soup to take care of it. And lots of clever people are working on this issue, and I figured that they'll take care of that as well. But that'll be important.
Okay, for you, Dr. Howe, I didn't even know there were differences in post-op care of splenectomy in Europe versus the U.S. So are there differences in antibiotic recommendations post-splenectomy in Europe versus the U.S.? And should asplenic patients in the U.S. have an emergency antibiotic supply?
Should have what was the last?
Should they carry an emergency antibiotic?
So we just make sure that people that have splenectomy are going to get vaccinated for pneumococcus, meningococcus, and Haemophilus influenza. And the vaccines for those keep changing, so it used to be you needed a booster every 5 years, but people didn't routinely have to take antibiotics. Now, it's probably different in the pediatric population where those people are more vulnerable, and I'm not aware of the European differences. So, yeah, so I don't, it's really those 3 organisms that we worry about. They have sugary capsules that allow them to evade, normal immune mechanisms, and the spleen is pretty good at helping to fight those off. So if you have the vaccinations, you develop antibodies to help you fight those bacteria if you were to come in contact with them. But I'm not aware that, losing your spleen is as important for the other types of bacteria. It's really mostly those 3 that we worry about.
And I decided, if you're going to become a missionary or go to certain parts of the world where meningitis is a higher prevalence, you are vaccinated against those types of things. And we do counsel people to have a much lower threshold to seek medical opinion if they are feeling unwell. And nowadays, with a lot of the viral things going around, you may feel unwell because you got COVID, which is going to be nothing to do with your spleen, but I think we just tell people have a lower threshold for getting medical advice.
And then one thing, I didn't really talk about spleen-preserving distal pancreatectomy. I kind of made it made it sound like we always take out the spleen. We try to save it when we can, and you can actually take out the blood vessels to the spleen when you take out the tail of the pancreas. I mean, it's frequent that you are going to do that, but there are blood vessels that connect the spleen to the stomach, and if you can leave enough of those smaller blood vessels intact, you can actually save the spleen and obviate the problem we're talking about. And we try to do that whenever we can.
Okay, while you have the mic, we have another one for you. Although it's on the same card, one is, should I worry about my NETs being genetic? And we have some standards for that. But then how do you deal with what is a common concern when people go into surgery, either for NET or for other issues, the whole opening you up and the risk of then NET cancer spreading just because of the operation in and of itself, or the exposure of those cells to oxygen?
Okay, well, those are two very different questions. So I'll answer the genetic one first. There are some conditions where people are predisposed to neuroendocrine tumors, and clearly for the pancreas specifically, multiple endocrine neoplasia type 1, where people get parathyroid and pituitary lesions, as well as these pancreatic neuroendocrine tumors. Von Hippel-Lindau syndrome, which is actually surprisingly common in Iowa. I don't know how common, but we see a lot of people with it. They get multiple pancreatic neuroendocrine tumors and pancreatic cysts, but the real hallmark of that is they get kidney tumors. That's the most common cancer that they get. And they also get hemangioblastomas in the back of their eyes and up in their cerebellum and along their spinal canal. So those people, there's genetic testing for. For small bowel neuroendocrine tumors, we actually spent a decade collecting families with multiple family members with them, and the NIH has been doing this as well. And they had about 64 families. We had about 26 families, and we did exome sequencing where we sequenced the DNA of everybody to try to find a causative gene, and we couldn't find one. And the NIH did find one in one family, but none of the other 63 families had mutations in that gene. So I would say the small bowel ones, although an occasional MEN1 patient will get a small bowel tumor, it's pretty rare. For most of those, we don't know of a genetic cause. And then the second question was, like, when you open somebody up, are you going to spread these tumors? Well, there's this kind of old wives' tale that when you open somebody up, the air gets to the tumor and it goes everywhere. That we don't believe is true. We believe that a lot of people have heard about relatives who had surgery, and when they were opened up, they had a very advanced tumor at the time of diagnosis, and they couldn't do anything with it. That I think is more common than saying what the air got to it and it spread everywhere. Clearly, if you rupture tumors, if you're taking out a tumor and you disrupt the capsule of it, it's possible that cells can implant, but it's a pretty uncommon event.
That's pretty much what I tell people too. I think it's more likely that the imaging prior to the operation anticipated the degree of involvement that you have, and so it's really more of a mind thing that the patients did worse than expected, and that's because the disease was worse than expected. Okay, so then Dr. Dillon, this is you versus the netrf.org. So I didn't even know, these are the types of things where I was like, we live in this world, I didn't even know. They had this on their website. So according to the NetRF, they are supposed to avoid overripe fruits, avoid wheat bread, avoid tomatoes, and avoid pickled things. I will tell you that other than the food sensitivities and maybe tomatoes being a little acidy, I have not ever recommended particular things you could.
I have Rachel's approach to it was the alcohol, wasn't it? If it makes you feel bad, don't do it. So so some of this relates to the fact that certain foods high in tyramine, aged meats, blue cheese, dark chocolate, red wine, have chemicals that can stimulate tumors to produce some of their hormones and chemicals which cause carcinoid syndrome, flushing, diarrhea, etc. So A, carcinoid syndrome only occurs in a minority of people. B, only a minority of people with carcinoid syndrome will have their symptoms precipitated or caused by any of these interventions. So if a person doesn't have problems with tomatoes, I say go for the tomatoes. So I have to talk to the folks at NEDORAF. Do you have anything on that, Rachel?
I think this is where the Food and Symptom Journal can really help empower patients, because you could have similar scans, similar 5-HIAA levels, and very different experiences of your carcinoid syndrome. And so what works for your friend who has a similar disease may not work for you, but tracking those, writing them down is going to be able to help you identify patterns of what foods trigger symptoms for you.
But some of those foods may interfere with some of the assays that we do, like checking serotonin levels. Like sometimes people will have these minimal elevations of serotonin, like our normal levels below 200, but there are a lot of people who live between 200 and 300 with no evidence of disease, and that's probably coming from things they ate, like avocados or nuts. It doesn't mean that they're having a problem with them, but it might interfere when they follow their serotonin levels.
Okay, and then back to you, Joe. Is lanreotide something that can be stopped on occasion? Are there circumstances where it can be stopped, or are patients on it forever?
So, lanreotide is there to do two things. It is there to inhibit the growth of tumors, and it is there to inhibit the production of hormones and chemicals which can cause symptoms. In people where their tumor is making hormones and chemicals which cause symptoms like flushing and diarrhea, they really don't want to come off of it because they feel really badly when they come off of it. And if they miss it for a week, they have really bad diarrhea and flushing and really don't want to come off of it. So the question really arises, I think, more in the group of people, in the majority of people who don't have carcinoid syndrome. So we're giving it for one reason. We're giving it to slow down tumor growth. Now,
Navigation care.
yes, very important. Okay, back to lanreotide. Oh, yes. So one of the, I think Dr. Hafdarnison alluded to it this morning about watchful waiting was an important concept in many people, because in many people their tumor grows so little or nothing from 6 months to nothing evident from 6 months to 6 months. If those people are immediately put on lanreotide, you look at them again in 6 months and say, wow, this is a great drug. Your tumor has not grown in 6 months. Whereas other people who are not put on lanreotide, their tumor is the same in 6 months. And we know that it wasn't lanreotide. So in people who have very stable disease, they're taking a brief break is something that I discuss with them.
That's a good thing you said that, because I've done it. I was just like, I hope he doesn't say that you're never supposed to come off that drug. I do give people a break from it. It's a really long-acting drug. If people are going on a trip, I would say, this is your bucket list, this is your life. Yeah. If you're going on a trip and you do not have a lot of syndrome, and even if you do have syndrome, I usually just send you with some short-acting octreotide, and I will let people, and I said, and if you want to stay off of it for around 4 or 5 months, it will slowly abate in your blood, in your system, to something that is unmeasurable. And then if you decide you want to scan and you see that it's all stable off of the drug, I'd even give you the option of staying off of it for a longer period of time.
Yep, absolutely.
I can't think of a time when I've gotten burned doing that.
The additional patient population for somebody who has disease progression on their somatostatin analog and has a non-functional tumor, that's a situation where when we transition to the next step in medical therapy, we will often stop the injection if there's not a functional syndrome to use it for symptom management.
Yeah, that's a good point. Okay, so the very last question I will answer. So I entered neuroendocrine actually in being on the transplant side of things. So someone has heard that transplants are not an option if the pancreatic neuroendocrine tumor is metastasized to the liver. So that is not a true statement. So within the U.S. and within the organ allocation system, transplantation, even multivisceral organ transplantation, is allowed in certain circumstances for patients with metastatic neuroendocrine. So there are clear-cut criteria. It is very patient-specific. The outcomes are quite good as long as you are within the Ki-67 of less than 10%. All the disease is removed at the time of transplant. So the issue, the nuance is that we are leaning more towards liver only, which sounds somewhat controversial since that's what Steve Jobs had. In pancreatic neuroendocrine tumor, because the upper cluster, which is when you take the liver and the pancreas, is prone to different types of transplant-related problems that were making it more difficult for people to do well. And so we will end up taking a surgical approach to the pancreas. So we will take out the pancreas primary, and then we will have some gap in time, X number of things that are dictated by the UNOS people, and then you are then allowed to get a liver-only liver transplant where the immunosuppressants that we use for a single organ liver transplant have never been shown to change the biologic behavior of neuroendocrine. So it's just a safe situation. But that there are criteria. So the answer is yes, transplant's an option. We even do outside-the-box multivisceral transplants, which are one of the largest transplants, if not the largest transplants we do for metastatic neuroendocrine, but there are specific rules. And if you fit into that and you are willing to take the leap into uncharted territory, it is actually a very reasonable option for people.
I was just going to ask if I can ask an embolization question.
Oh my God, you can. There are embolization questions.
We couldn't let him get away without having to answer one.
Absolutely.
So for patients who have carcinoid heart disease, we heard how liver surgery might be more difficult. Are there considerations for embolization we need to think about?
So with embolization, like we can do it. I mean, there are some patients we can do with IV sedation for sure, and that does not put a lot of stress on the heart and the lung function. And we can even do it with local anesthesia. So liver-directed therapy would still be an option, is what I would say.
Okay, Michael. I managed to get through the slides. Thank you guys all very, very much for coming.